Thanks, Costello, and I appreciate the flexibility of everybody sort of being able to maneuver like that. That's great. I'm very appreciative to be here, at least, not in the least of which is because I've seen so many friends and colleagues who I haven't seen for quite some time. But I want to use the time smartly, so I'm going to get started without any ado here. I'm not going to spend time on this slide. Prevention works. There are many, many programs, and you heard all about the fact that they're growing exponentially. But the problem is it's not scalable and sustainable. I've spent many years of my career trying to implement prevention programs, and when the grant funding runs out, when the government changes, the governor changes in our local area, the funding dries up, and the next big wave of enthusiasm starts for something else. And so I have become convinced that right now in our current medical system, and Dr. Frank, I don't see him yet, but he's speaking a little bit. Oh, he's back there. So after 10 years of sitting on the MacArthur Mental Health Policy Committee with Richard and many other meetings with him, I finally become convinced that the only thing that really matters is, does it get paid for? And because our system figures out what to do about all the other issues once it gets paid for. And right now, prevention doesn't get paid for because it's in diverse settings. They're not licensed sites. They're not considered medical settings. It can't be reimbursed. For example, in Ohio, the telemedicine laws say they must be delivered at both ends in a medical setting. And as a result, we cannot implement preventive services in a lot of other settings where the kids are. We have to use unlicensed professionals in many of our preventive interventions because it makes them less expensive, and therefore, again, they're not reimbursable. We use group interventions and universal interventions, and without a diagnosis, CPT code, ICD codes, we don't get reimbursed. And we require a specific patient rather than a universal setting. So again, we are not able to reimburse preventive services, at least in Columbus, Ohio, where I live. Now, there are a couple options for trying to do things. Our traditional approach is the non-governmental organization, the hospital, the foundation, the agency, the community group, and you get grants and donations and you run out, but we don't develop infrastructure, we don't develop professional development, and we are ineffective at maintaining services and delivering them at a high professional level. Regulatory and legislative solutions, they aren't so great either. We have specific mandates needed. You have to be particular. The legislation requires specific programs, and they're piecemeal and must be constantly updated, and we use up all of our political favors on particular pieces of legislation for particular programs, and as legislators change and roll over again, we lose out. So I have become a fan of the Michael Porter School for all his other issues, Harvard Business School, that creating shared value between businesses and social agencies is the only hope we have of sustaining and scaling. We have to identify the social good and what is the business opportunity in that, and it requires clear outcomes measurement, intensive data collection, and alignment of incentives for both the business partner and the social good. And I want to talk to you about what we're trying to do in Central Ohio as an example, and then come back to how to wrap that up. So basically, in Central Ohio, Nationwide Children's Hospital and 800 physicians have formed a physician hospital organization. It's now 10 years old, called Partners for Kids. They have taken on capitated contracts as an intermediary organization, according to the official laws of Ohio, as an insurance licensing group. But it's really an accountable care organization defined in the federal laws. And that has 34 counties, contracts with all Medicaid managed care children in these 34 counties are enrolled in a single accountable care organization. This is how the World Health Organization says, ideally in a horizontally integrated system, the money would flow. I have this up here so you can look at it later. I'm not going to read it, but this is how we do it in Ohio. The Ohio Department of Jobs and Family Services, now moving to the Ohio Department of Medicaid, contracts with plans, Medicaid managed care organizations like almost every state has. And these Medicaid managed care organizations take off an administrative fee and pass all of the resources, the capitation fee, down to the Partners for Kids, PHO. PHO pays its various provider groups. I can talk about the distinctions between the different provider groups later, but the point is the entire financial and clinical risk, outcome measurement and total cost is captured within the PFK. This is what happened then. Asthma was the largest chronic disease faced, and this is the path for asthma prevention that was taken on by PFK because it was our largest cost in a chronic disease. This is what happened with the per member per month cost for prematurity, which accounted for 28% of all the costs in thing. Prematurity and NICU days are one of the most expensive conditions in childhood. And this is what happened with complex care kids, G-tubes, children with preventable conditions. These are chronic neurologically impaired G-tubes, tracheostomies, very complex children. The point is, the business model requires that the hospital and the providers recognize lack of coordination and lack of preventive services in each of these groups and go out and actually install school-based asthma therapy, home monitors for kids on G-tubes, and other preventive measures to keep kids out of the hospital because now they are at risk for the hospital care. And we'd like to think they would do that anyway, but the coordination motivation was not there previously to invest a priori in preventive services. You're saying, well, Kelly, that's not prevention for behavioral health. What do we do about that? Well, first, I just want to show you the overall business model. This is the Medicare Consumer Price Index at the top, the rate of inflation each year during this time, and it's 3.5%. Ohio said that their Medicaid inflation during the same time was 4.5% each of these years on average. The Partners for Kids red line averages between 1.5 and 2% the whole time. So rate of inflation and growth in the overall model of capitation on an $800 million contract for a hospital was 1.5 to 2% below the state average, and these monies were retained by the hospital and its services to invest in prevention. Well, behavioral health is a problem for these businesses as well, and it's a problem for our children. Behavioral health, we have extreme access problems, especially in rural and inner city areas. 1/3 of the pharmacy costs. So the pharmacy bill for Partners for Kids last year was $200 million. And 1/3 of that is behavioral health drugs. And those are the most rapidly rising drugs, and they're the most expensive, and they're twice as likely to be prescribed in low access areas. $8 million on Abilify, $25 million on ADHD drugs, and the most common reason for kids to be readmitted are behavioral health problems. So we are not effective at getting our behavioral health services out in the community. Okay, there we go. So the first focus was, can we address children who have behavioral health admissions? And with case management, home monitoring, and consultation on the telephone, we're able to drop behavioral health readmissions significantly over the last few quarters. However, the business people and the clinicians know that the real prevention of mental health problems and the real reductions in the use of psychiatric drugs and admissions and other problems has to do with preventive services. So we've identified 10 neighborhoods that account for about 40% of all the admissions in our inner city areas, and all behavioral health kids come to the emergency room. The first neighborhood is called Healthy Neighborhood, Healthy Family Zone. It's called Southern Orchards, and it's a 40-block area that has 2,000 children. They're overwhelmingly poor, minority, and low income. And we've started to implement some preventive services there. This is the Philadelphia model of block cleanup, cleaning out gang areas where the guns and drugs are kept on the street in abandoned lots and houses, and small fences are put up in play areas and gardens. Reduce crime in Philadelphia and St. Louis by roughly 34%. These are a picture from one of our bike co-ops. The hospital is co-sponsoring 2 bicycle co-ops in the neighborhood to keep the kids off the streets during the summertime, allow kids to earn bicycles. You say, well, Kelly, these aren't some of our preventive efforts. So this is Good Behavior Game, Incredible Years, and home visiting with the Spark Literacy Program out of Akron and Cleveland. And this is the proposed interventions that are being introduced and supported by the hospital and the Partners for Kids organization over the next few years. The Good Behavior Game is already in 15 schools in Licking County, a county adjacent to Franklin County where Columbus, Ohio is. We're expanding 5 schools per year, and in Southeast Ohio, the rural area, 5 additional schools per year. incredible years, 5 schools per year for Franklin County for parent groups and in preschool and kindergarten, and expand preschool 60 slots per year in these neighborhoods where preschool is not required and currently in Ohio not mandated. For adolescents, we're offering the Safer Choices, the CDC thing on dating violence and reproductive choice and depression screening. And with foster care and juvenile justice, a patient-centered medical home project, because these are the kids most likely to get unintentionally pregnant, to be admitted to the emergency room, and have psychotropic drugs. And lastly, a foster mentoring program that is maybe not evidence-based, but is the one that right now is available in Columbus. So the hospital and the physician hospital organization have committed to introducing these concepts because long-term growth of the community and the health of the community are critically important. We've also set as goals reducing unemployment in these 10 neighborhoods, and the hospital has set aside 50 jobs per year to hire people from the neighborhoods as part of this initiative, because without healthy neighborhoods, we're not going to have healthy kids. So you say, well, Columbus may be different, you've got a lot of money, and there's a lot of resources at Nationwide Children's Hospital. These are the other children's hospitals that are taking on risk-bearing entities, and about half of these are taking on preventive neighborhood initiatives. I don't think it's just unique to Columbus. I think it's actually the beginning of something that the hospitals are understanding is not only their mandate from an ethical pure purview, but it's also a business mandate. And each of these hospitals has risk-bearing entity contracts right now. Most of them are much smaller, but they're growing rapidly. I'm going to just briefly mention, this is not the only model that I think is important for changing payment reform. First of all, we have a rural model that, which we are partners with. The Interagency Partnership for Appalachian Children is a group of rural agencies in southeastern Ohio, and they have banded together, and Partners for Kids and Nationwide Children's Hospital actually pay for outcomes. So these are social service agencies, and every time they enroll a child in Medicaid, they get paid a flat fee. Every time a teenager delivers a healthy baby with early prenatal care, they get paid a fee. Every time they enroll somebody in long-acting reversible contraceptives, they get paid a fee. If teenagers graduate and after participating in our Safer Choices program in rural areas, they get paid a fee. So the just pay for outcomes model out of a hub is also very popular in our rural communities where we can't get critical mass of all the professionals around to do the other programming. I think the growth in the next wave, we're already speaking with the governor's office on several of what's called socially accountable care organizations. You may have seen it referenced in the literature out of New York as totally accountable care organizations, or TACOs. And the idea here is that not only should the accountable care organizations be contributing to the medical aspects and the business model on the medical side, but there are social responsibilities. So foster care, juvenile justice, and school-based mental health are all being considered by the governor to roll in under the capitation arrangement with contracting to try to spread the model so it is able to capture more children, especially these high-cost children. And I'm not going to talk about social capital bonds, SOCAP bonds. Nationwide Children's and a couple other hospitals are participating in the Federal Reserve meeting next month on social capital bonds where investors, private equity takes on risk for improving social goods, reducing prison recidivism, or keeping kids out of foster care. But I think Dr. Frank's going to talk a little bit more about that. So I think there are a couple other levers that would help all of these things move along. We do not have national telemedicine standards and national standards for rolling out these issues, and these models are highly restricted geographically as long as we don't have standards nationally to change things. Secondly, without integrated behavioral health and primary care, we are not going to make a lot of progress on many of these issues. And I know there's some concerns about mental health exceptionalism for the most severely ill, mentally ill, but I believe those can be overcome with some of these outcome measures and metrics. And thirdly, integrated foster care and juvenile justice services cannot be maintained as separate things because they're isolated and there's no accountability and monitoring of resources, expenses, and the outcomes of kids. So I think payment reform is the only lever that's really mattered in Ohio, and I believe has a lot of potential to matter nationally, to really scale and sustain prevention, because I've never seen growth of preventive services and at getting the accountants and business people on board with these services until we're able to deliver true outcomes like this. I think the current market is focused right now on just some of these exclusively pediatric organizations, but I believe as other larger organizations, the large accountable care organizations will get it. And lastly, I think that social capital bonds deserve special study for isolated populations like juvenile justice. Thank you.
Okay, thank you very much. Our next speaker will be Eric Bruns.